Hello, my name is Gervasio and I am extremely grateful to the Argentinian Society of Neurosurgery and all of its esteemed representatives for this invitation. Today, I will be talking about the role of magnetic resonance imaging in peripheral nerve surgery. Magnetic resonance neurography assists in the diagnosis of peripheral nerve pathology, creates a preoperative roadmap for the peripheral nerve surgeon, and serves as a useful technique for postoperative follow-up, as is well pointed out by the authors of this American study from 2012. Magnetic resonance neurography was first proposed by Filler in 1992. This technique mainly includes diffusion-weighted imaging and T2 fat suppression imaging. In 1992, Aaron Filler and Franklin Ho, working at St. George's Hospital Medical School in London, succeeded in identifying the unique water properties of nerve water that will make it possible to generate tissue-specific nerve images. Here we can see a depiction of the nerve water compartments. Important nerve water components with unique characteristics for MRI include the endoneurial fluid, exoplasmic water, organelle water, and myelin-associated water. MR sequences can be optimized to detect water signal arising in one of the several compartments. The clinical pathology data in T2-based MR neurography appears to derive from alterations in endoneurial fluid content in nerve. Endoneurial fluid is a low-protein fluid with long T2 confined to the endoneurium of nerve fascicles. Compressions or irritative processes appear to be capable of increasing the amount of this fluid relative to the other cellular components of the fascicle in a variety of pathological conditions. In the MRN, we will therefore be highlighting the swelling and hyperintensity of the nerve. Due to abundant perineural and intraneural fat interspersed among the individual fascicles, fat suppression sequences are helpful in distinguishing the fascicular pattern of the nerve from adjacent vessels and are most useful for assessment of abnormal nerves due to pathologically increased endoneurial fluid, which could indicate nerve injury or entrapment. Water and fat signals for MR imaging can be separated by exploiting the diversity of their magnetic property and water-fat chemical shift. This gave birth to fat suppression techniques deployed for the MRN. Fat suppression is essential for detailed evaluation of peripheral nerves. Ever since the first application of these techniques by Filler to present day, the development of MRN continued to progress. Utility for MR neurography has now been established in nerve tumors assessment, evaluation of entrapment syndromes, nerve injury, evaluation of repair, neuritis, and neuropathies, and for evaluating nerve disorders affecting the young pediatric patient, such as obstetrical brachial plexus palsy. The usefulness of the magnetic resonance in the diagnosis of peripheral nerve sheath tumors is known to all. The MR allows us to view typical signs in neurogenic tumors: split fat sign, target sign, entering and exiting nerve sign, that can be seen in the pictures on the right. Peripheral nerve tumors are characterized by T1 iso-hypointense fusiform mass in continuity with the nerve. The split fat sign depicts the well-defined tumor surrounded by a layer of fat on T1 weighted images, wherein the hyperintense fat around the fusiform mass suggests intermuscular location of the lesion. The target sign shows high signal intensity in the periphery and low signal intensity in the central portion on T2 weighted images, corresponding to the higher fibrocollagen content in the center, which correlates with the organized histological architecture. Magnetic resonance neurography can directly display the full length of a nerve and its invasion by a PNST in addition to showing intraneural and extraneural lesions. Fascicular patterns may be detected within the mass, which supports its neurogenic origin. If the tumors do not originate from the nerve, MRN can show whether the nerve has been invaded or pushed by tumors, and the relationship between the tumor and surrounding tissue. These radiological findings are important for the selection of surgical approaches. MRN is used to identify the nerve origin of a tumor and the extent of its involvement before surgery. Therefore, both the surgical field and the invasiveness of surgery can be minimized. Morphologic MRI sequences can help in assessment of entrapment neuropathies. Preoperatively, the magnetic resonance gives us a precise definition of nature and localization of the pathology for surgical planning. MR neurography has fewer limitations for assessing deep or difficult anatomic areas. It is accurate in determining the cause, site, and extent of peripheral nerve injuries and identifying other related findings, such as signs of muscle denervation or fluid collections or bone and soft tissue alterations. The MR also allows us to identify anatomical patterns preoperatively. For example, even in a common pathology such as the cubital tunnel syndrome, the one which is believed to be the standard anatomical layout just happens to be the most frequent. We can, for example, find ourselves in the presence of an epitrocleoanconeus muscle with a corresponding anatomical pattern featuring a prominent medial head of the triceps, as we can see on the right. The impact of anatomical variations is reported to be from 1 to 30% in healthy individuals and in cadaveric studies. In our retrospective analysis of a series of 122 cases operated with ulnar nerve compression at the elbow throughout 11 years, the 25% of the patients featured anatomical muscle variations, while 15% presented ulnar canal anomalies. Overall, 40% of the patients featured more than just a simple thickening of the capital tunnel roof. In the post-operative timescale, the MR is useful in monitoring the functional recovery of both the nerve and the muscles innervated from it. It has prognostic value on the extent of the recovery. Involvement of a given muscular group can be used as a clue for detection of a specific nerve trunk injury. For example, the STIR hyperintensity of the flexor carpi ulnaris and of the flexor digitorum profundus medial half suggests a suffering of the ulnar nerve at the elbow, which is responsible for the innervation of those muscular areas. Morphologic MRI can help in the differentiation of the muscle denervation stage. In the acute and subacute phases of peripheral nerve injury, involved muscles show high signal intensity with fluid-sensitive sequences. In the chronic stage, there is fatty infiltration, which characteristically appears as areas of high signal intensity on T1 weighted images, and muscle atrophy. Muscular denervation changes identified at MRI can be carefully evaluated together with clinical and electrophysiologic changes during follow-up, as they all have an effect on patient outcome. Now we shall examine some clinical cases as examples of the use of the MR in the pre- and post-operative period of the ulnar nerve compression at the elbow surgery. Here we have a 40-year-old woman with a severe compression of the right ulnar nerve at the elbow, Dallon-free, confirmed by the EMG. The preoperative MR shows a prominence of the triceps medial head, a thickened cubital tunnel with a partially muscular wall, and particularly swollen ulnar nerve in the area between the two compressions with neuroma-like characteristics. Here we can see that the full arrow is pointing towards the ulnar nerve, while the arrowhead is pointing towards the prominent triceps medial head, as we can also see in the corresponding intraoperative pictures. Here too, in the T1 pictures and in the T2 fat saturation pictures, the arrow points towards the ulnar nerve, while the arrowhead towards the prominent triceps medial head, as we can also see in the corresponding intraoperative pictures. Here, the arrow is pointing towards the cubital tunnel, and the arrowhead is pointing towards the swollen and hyperintense ulnar nerve, as well as in the corresponding intraoperative images. Here, the arrow points towards the swollen ulnar nerve, with a neuroma-like appearance with the corresponding intraoperative pictures. Here we can see a comparison between the pre- and post-operative pictures. The arrow points to the ulnar nerve, which is no longer swollen in T1 in the post-operative, and no longer hyperintense in T2 with fat saturation. The arrowhead points to the triceps medial head, which is no longer prominent after the plastic surgery. The arrow is pointing towards the ulnar nerve, which is no longer swollen and hyperintense in the postoperative, while the arrowhead points towards the cubital tunnel, no longer noticeable after the section in the postoperative. Here we have a 63-year-old man with a severe compression of the right ulnar nerve at the elbow, Dallon 3, confirmed by the EMG, with a strong muscular atrophy. The preoperative MR shows a suffering of the flexor digitorum profundus, fatty atrophy of the flexor carpi ulnaris muscle. It also shows a slightly thickened cubital tunnel with light muscle strengthening. Osteophytosis of the ulnar canal with ulnar nerve compression determined by an osteophyte of the region of the humeral medial epicondyle. In the upper area, the arrowhead points towards the suffering and STIR hyperintense flexor digitorum profundus on the left, and on the right, the fatty atrophy of the flexor carpi ulnaris in T1. The arrow is pointing towards the ulnar nerve. On the lower side, the arrowhead points towards the slightly thickened cubital tunnel with T1 muscle strengthening and intraoperatively. Here, the arrow points towards the ulnar nerve, while the arrowhead points towards the osteophyte on the left in T1, and on the right intraoperatively. On the lower side, we can appreciate the osteophyte's drilling. Some spongostan is applied on the drilled surface without having to suture the periosteum with the use of a personal technique. The medial collateral ligament of the elbow gets spared while remodeling the ulnar canal, in between pre- and post-operative. Here we have a 13-year-old girl with positive familial history for compressive neuropathies. We can see a severe compression of the right ulnar nerve at the elbow, Dallon 3, confirmed by the EMG. The preoperative MR shows the prominence of the triceps medial head, thickened cubital tunnel with almost totally muscular wall, swollen and hyperintense ulnar nerve all throughout the course. The arrow is pointing towards the ulnar nerve, while the arrowheads point towards the cubital tunnel with muscle strengthening both in the MR and intraoperatively. The arrow points towards the ulnar nerve, while the arrowhead points towards the prominent portion of the triceps medial head before, during, and after the section. The arrow is pointing towards the prominent triceps medial head and the tunnel with muscle strengthening in T1, preoperatively on the left and after coming back to normal postoperatively on the right. Here, the arrows point towards the hyperintensity with suffering of the flexor digitorum profundus, present preoperatively in sequences with fat saturation and STIR on the left, which regresses postoperatively on the right. Here we can see how the betterment of the width and motor conduction velocity in the AMG corresponds to the regression of the alteration of the muscle areas in the magnetic resonance. Here we have a 31-year-old man with a compression of the right ulnar nerve at the elbow of medium ranking, Dallon 2, confirmed by the AMG. The preoperative MR shows a persistence of the epitrochleoanconeus muscle with compressive suffering of the ulnar nerve on that level. A constant anatomical association with prominence of the triceps medial head is made. The arrow is pointing towards the epitrochleoanconeus muscle, which is a phytogenic residue. The arrowhead is pointing towards the ulnar nerve, which appears to be compressed and hyperintense in STIR in the lower area. Intraoperatively, the epitrochleoanconeus muscle gets dissected and excised, while the prominent triceps get dissected, freeing the ulnar nerve. The arrow points towards the mark left on the nerve by the epitrochleoanconeus muscle. The effective use of the MR is well established in the diagnosis of tumors and entrapment neuropathies, but it also proves itself useful in the event of difficult-to-diagnose and infrequent pathologies. Let us see an example. A 31-year-old woman with a previous removal of a right SPE schwannoma presented a neuralgia paresthetica from about 8 months, resistant to medical therapy. There were signs of a positive tunnel in the anterolateral upper portion of the right thigh, at the level of a painful swelling. There is an area of hypoesthesia and dysesthesia on the upper portion of the anterolateral side of the right thigh. There were no motor deficits nor other sensory deficits. The electroneurography showed the suffering of the lateral femoral cutaneous nerve. At the level of the anterior superior iliac spine, the MR highlights a hypointense subcutaneous tumor in T1 and hyperintense in STIR with fat suppression, which proves itself to be a feasible cutaneous dorsal branch schwannoma of the lateral femoral cutaneous nerve. The MR of the pelvis points out another feasible schwannoma on the right femoral nerve in the pelvis, which is quite visible in STIR sequences with fat saturation on the left. On the right, we can see the anatomical picture. Thus, we proceed to the surgery of the electrophysiologically and clinically symptomatic lesion of the lateral femoral cutaneous nerve dorsal branch. There is an identification of the nerve at both poles of the lesion. There is also an identification of the bare area for the incision. Then we have a removal of the lesion with coagulation of the single feeding fascicle of the lesion. Then we have a preservation of the continuity of the nerve bundles and juxtaposition of the epineurium with no need of a suture. Here we have an aesthetic intradermal suture. The histological exam has pointed out a conventional Antoni type A schwannoma. The postoperative MR after 1 month and 2 years showed the comprehensive removal without any recurrence in T1 and STIR with fat saturation. Here we have some coronal images in STIR and in T2 with fat saturation. In T1 with fat saturation and with a contrast enhancement. We have a lack of vestibular schwannoma in the fiesta sequences of the encephalon. A brain and spinal MR has been carried out with contrast enhancement. It was negative. The study of the pelvis showed the other lesion untouched in T2, STIR, and T1 with fat saturation and contrast enhancement. The outcome has highlighted a comprehensive and stable regression over the time of the meralgia paresthetica, lack of altered sensitivity areas and improved potential width, and normal sensory nerve conduction velocity when studied with the ENG. In the genetic testing, there is no evidence of NF2 SMARCB1 and LZTR1 mutations. The clinical case featured diagnostic criteria for schwannomatosis. Take-home messages. In the event of multiple schwannomas, the execution of the high-quality MRI, including brain, 8th cranial nerve, and spinal cord, is important for an accurate diagnosis of the case, even a genetic one. NF2 and schwannomatosis have different prognosis. Here is another example of the fundamental usefulness of DMR in peripheral nerve pathologies. Magnetic resonance neurography has also been proposed as a useful tool for assessment of post-surgical outcomes and complications in patients who have undergone surgical repair of peripheral nerve injuries. The future is represented by the exploitation of functional MRI techniques such as diffusion-weighted imaging or diffusion tensor imaging. These techniques provide not only morphological but also functional information about extent and degree of nerve impairment. Functional magnetic resonance neurography can be applied to selection, planning, and monitoring of surgical procedures, as it provides surgeons with valuable information about the functional status of the nerves involved and axonal flow integrity. MRI provides irreplaceable anatomical information, supplementary to clinical and electrodiagnostic findings. The intrinsic structure of peripheral nerves involves the existence of several biologic barriers that facilitate water movement along the long axis of the nerve and restrict free water diffusion along the perpendicular axis. These features support the behavior of peripheral nerves at both DWI and DTI neurography. DTI also provides quantitative information through several biomarkers, such as fractional anisotropy and radial diffusivity. Fractional anisotropy is the most important parameter derived from DTI and enables neurographic reconstructions. Fractional anisotropy is a sensitive parameter and indicates the degree of fiber organization. A reduction in fractional anisotropy reflects loss of fiber integrity and normal anisotropy of the peripheral nerve structure, which can be due to an increase in extracellular water, as occurs in moderate peripheral nerve injury or damage of the inner or outer connective layers in major nerve injury. Furthermore, 3D reconstructions of DTI neurography data provide reconstructions of the entire nerve path. Fibers beyond the suture site can be considered a sign of successful surgical outcome. RD informs about the integrity of the myelin sheath. After neurography, nerve regeneration can be characterized using quantitative information derived from DTI neurography, as it typically shows an increase in FA and a decrease in RD. A reduction in RD can be considered a specific parametric sign of remyelination. Persistence of low FA and high RD can suggest failure of the surgical procedure and poor prognosis. Parameters derived from DWI and DTI can be potential biomarkers for neural damage and regeneration. High-resolution MR allows direct visualization of the nerve with precise anatomical details and points towards the etiopathogenesis of the disorders, facilitating better clinical decision-making and patient management. It allows us to plan the surgery, the type of anesthesia, and therefore makes us able to inform the patient in the most comprehensive way possible, both preoperatively and postoperatively, on the extent of the recovery. The introduction of imaging techniques capable of demonstrating the intrinsic signal of nerve as well as of displaying structural linear properties of neural tissue is progressively transforming all of neuroimaging, even as it transforms our approach to diagnosis, treatment planning, and surgical access, bringing us to a new era. In conclusion, advanced imaging is revolutionizing the approach to peripheral nervous system pathologies, driving us towards a groundbreaking and multimodal approach, charming to the new generations, that can be compared, as suggested in this study, to the neoteric approach of the Poetae Novi of the 1st century BC. That said, thank you very much for your kind attention, everyone, and have a good day.